I call upon Dr. Hemalatha, the next speaker. Dr. Hemalatha, it does MBBS from Ballari Medical College, DA from JJMMC Davangere, and MD from KMC Hubli. She worked in various capacities in Department of Anesthesiology, from tutor to the post of professor, and attained superannuation in April 2022. She joined CIMS in June 22 as a professor, attended many CMEs and conferences of state and national level, and delegate as a invited speaker and as a chairperson. As scientific committee chairperson, she is organizing secretary of CMEs at JJMMC. Recognized BLS and ACLC instructor since 2011 till date. Coordinator of BLS and ACLC at JSS Medical College from 2016 to 2020. Done her certificate course in Essentials of Palliative Care and Faculty for Palliative Care courses at JSS Medical College. Recognized PG teacher since 2003 and guided dissertations of more than 15 MD students till date. Case reports on original articles in IJA and Indian College of Anesthesiology and other journals. She is a life member of ISA, IMA, JOACP and AOA. Please take over. Thank you.
Good afternoon. Thank you, sir, for that kind introduction. And I bring greetings from Chamarajanagar Institute of Medical Sciences, Chamarajanagar. And I'll be speaking on the perioperative management of hyperglycemia under the following headings. Introduction, why hyperglycemia needs to be treated, a metabolic or stress response, and hyperglycemia, it's not only seen in diabetics but also in non-diabetics, so definition and recognition. Glucose monitoring in the perioperative period. Management again is divided into pre-op, intra-op and the post-op periods. And a few words about hypoglycemia and the conclusion. So we all know that the prevalence of diabetes is increasing all over the world. So almost amounting to more than 500 millions. And that is increasing in our country also, and India is becoming the world capital of diabetes. So naturally, we see this as one of the most common or the second most common comorbid condition in the surgical patients, and they usually account for about 15% of all the surgical lists. So they come for surgeries either related to the target organs or the non-target organs, for example like hernia. And why should we treat this hyperglycemia in surgical or the critical care settings? And we know that there is a metabolic stress response due to the surgical trauma, and this alters the glucose homeostasis, and this resulting hyperglycemia is a risk factor for the following things. One is the postoperative sepsis, endothelial dysfunction that occurs in the vessels, leading on to vasculitis, sometimes may lead on to very serious complications like acute coronary syndrome or the heart failure, cerebral ischemia leading to stroke, and impaired wound healing. And this stress response may lead on to certain metabolic complications, serious metabolic complications like diabetic ketoacidosis or hyperglycemic hyperosmolar non-ketotic syndrome. And this treatment of the patients, reducing the complications, everything definitely lessens the economic burden both on the hospital as well as the patient. And they have found, many studies have found that there is a dose-response relationship between severe hyperglycemia and the complications. So higher the blood glucose levels or the HbA1c levels at the time of admission, more the incidence of postoperative complications. Now I'll tell in brief about the metabolic response to surgery. Hyperglycemia develops as a because of the complex interplay between the counter-regulatory hormones that are released because of the surgical trauma, and there is a peripheral insulin resistance, especially more so in the post-operative period. And this magnitude of this stress response depends on the extent of surgery, duration of surgery, and the type of anesthesia. And this flowchart describes this. And these metabolic changes, stress response get worsened in diabetics. So usually the stress response happens in everybody, but this comes down or disappears once the stress, that is the surgery is removed or surgery is over. But this gets worsened in diabetics in whom already there is deficiency of insulin. So all this results in gluconeogenesis, glycogenolysis, proteolysis, lipolysis and ketogenesis. So if untreated, this may lead to serious complication like DKA. And this insulin resistance means there will be the tissues, the peripheral tissues cannot respond to the available insulin. So definitely the blood glucose rises. And what are the effects of anesthesia are certain interventions that we do during the intraoperative period. So among the intravenous anesthetics, etomidate is known to decrease the blood levels because of its adrenocortical suppression. Among inhalational agents, isoflurane and halothane are known to increase the blood glucose levels, probably by inhibiting the glucose-triggered release of insulin. And muscle relaxants, we don't find any significant effects on the blood glucose. Benzodiazepines, they decrease the blood glucose by reducing the ACTH and the cortisol levels. Opiates decrease the blood glucose levels by reducing the catabolic hormones. And coming to regional anesthesia, we all know that the stress response is less compared to general anesthesia. And regional anesthesia including central neuraxia. Among the central neuraxial blockade, subarachnoid block or the epidural is known to reduce stress response by modulating the action of catabolic hormones and the insulin. The activation of sympathetic nervous system and HPA axis is avoided in this central neuraxial blockade. And studies have also found that there is reduced insulin resistance in the early postoperative period. So ASRA guidelines has given certain guidelines, especially during in patients with symptomatic peripheral neuropathy. One has to reduce the concentration and the dose of the local anesthetics. We have to avoid adding epinephrine to local anesthetics. And USG guided, anyhow we are all now so familiar with the USG guided techniques that are better because you always avoid injuring the nerves by keeping the needle slightly away from the nerves. Now, we use certain adjuncts during intraoperative period that affect the blood glucose values, and most commonly used drugs are steroids. Among the steroids, most commonly used drugs are dexamethasone and hydrocortisone. Hydrocortisone, of course, may be used for an emergency like any problem with the airway or in known cases of asthmatics or COPD. But most widely used drug is dexamethasone of late is to prevent PONV. And studies have reported that there will be increase in the blood glucose levels, definitely. But when they have studied the incidence of surgical site infection, there is no significant surgical site. However, one has to be judicious when you are using these drugs in diabetic patients. And addition of epinephrine to local anesthetics also is known to increase the blood glucose level. And blood transfusion, post-transfusion, studies have reported that there will be increase in the blood glucose value because of the release of blood glucose from the RBCs. We all know that RBCs contain glucose, and also because of the addition of the plasma glucose to the existing glucose value. So now we have to identify certain conditions. So we have to know the definitions of certain things, mainly divided into diabetes, means diabetes mellitus in whom already it is established and patient is already on treatment. And there is an entity called stress hyperglycemia in patients who have no history of diabetes, but we find hyperglycemia, that is almost more than 180 milligram per deciliter persistently, but it usually disappears once the surgical stress is removed. And one more entity known as undiagnosed diabetes, or people who have been detected to have found to have high blood glucose levels in whom there was no prior history of diabetes. So one has to differentiate between these two conditions only by doing HbA1c levels. So what are the criteria? So American Diabetic Association defines, has given certain criteria to diagnose diabetes. Fasting blood glucose should be more than 126 milligram per deciliter or more than 7 millimoles per liter. Postprandial blood glucose more than 200 milligrams for a load of oral glucose load of 75 grams, and HbA1c more than 6.5. Some people give margin up to 7%. And classic symptoms of hyperglycemia with a random blood glucose of more than 200 milligrams. So it recommends that in all patients in whom you find blood glucose to be more than 140, if at all HbA1c is not done in the previous 3 months, better to do a HbA1c. So this, as I already told, helps us to differentiate between the newly detected diabetes from the stress hyperglycemia. Now, before I go on to the management, I would like to tell about what are the types of glucose monitoring that are existing. So, one is the point of care testing. Usually, we all know that it is very commonly done and test capillary blood glucose and using a glucometer. So, the advantage is the results are very quick, but it has got certain limitations in certain conditions like rapidly changing hematocrit, hypoxia or acidosis, use of vasopressors, peripheral edema, and in critically ill patients. So, all these affect the accuracy of the result. The second method is the most commonly used central laboratory testing. The results are very accurate, but the results take longer time when it is urgent, like in the intraoperative period, it is not very practicable to use the central lab values. The next method is ABG or the arterial blood gas analysis. This is also widely used, especially in critical care situations or maybe cardiac setup. So, these are also the results are very close to the central lab values and quick results are obtained. This is definitely the accuracy is better than the capillary sample or the analysis of arterial samples using glucometer. The fourth one is the continuous glucose monitoring or the CGM. Now, this is becoming very popular, but so definitely it helps us to detect both the types of dysglycemia, that is both hyper as well as hypo. And many studies have reported that in spite of patient being hypoglycemic for 15 minutes, the patient wouldn't have complained of symptoms of hypoglycemia. That is the advantage of having CGM. So, it helps in maintaining the target blood glucose values, but the limitation is the sensor is placed subcutaneously and it measures the interstitial fluid glucose level. So, anything that affects the interstitial fluid hypoperfusion, like major shifts in the intraoperative fluid or edema, and in patients who are requiring vasopressor. So, this affects the accuracy of the results. Now, coming to the perioperative management per se. So, this can be broadly divided into preoperative, intraoperative, and the postoperative management. So, this flowchart describes the pre-op management, and so I will be telling briefly. So, preoperative management definitely requires a thorough preoperative evaluation with a detailed history of the disease and the treatment. And during clinical examination, one has to look for signs and symptoms of autonomic neuropathy, especially if the patient is having postural hypotension and is a long-standing diabetic. Assessment of airway, one has to look for the cervical spine movement because of the deposition of the glycosylated proteins, and that's called stiff joint syndrome. And if planned for regional anesthesia or the central neuraxial blockade, always nerve damage or the extent of neuropathy has to be documented prior to giving the block. And fundal examination, the studies say that it helps us to predict the visual loss in the post-operative period. There is a spelling mistake, sorry for that. And one has to not only concentrate on the diabetes, we have to look for other comorbid conditions like hypertension, any thyroid disorder or any cardiovascular problem. And if patient is already diabetic, check for the adequacy of the glucose control by doing FBS, PPBS and HbA1c if it is not done in the previous 2 to 3 months. And British guidelines also have recommended HbA1c should be done, better to be done in patients with DM risk factors, that is diabetes mellitus risk factor. They may not be diabetic, like age more than 45 years, patients who have got dyslipidemia, hypertension, patients who are obese and sedentary lifestyle, or patients who have got history of PCOS. And one has to look into the details of the treatment that the patient is taking, that is whether it is OHA or insulin. And one has to look for the complications, investigations that lead us to the diagnosis of the micro and macrovascular complications by doing blood urea nitrogens, creatinine, serum electrolytes, especially potassium, recent ECG and echocardiography whenever required, or better to do in these cases because there is reports of silent ischemia in these patients, myocardial ischemia. So, what is the decision or what should be the goals to accept the patients for surgery? So, for an elective procedure, the ideal goals are FBS should be less than 120 and PPBS should be less than 180 milligram per deciliter, and HbA1c ideally should be less than 6.5%. And what are the factors that influence the decision for accepting the patient for surgery? So it all depends on the duration of surgery, like whether patient and the surgery is going to last more than 4 hours or less than 4 hours, or whether it is a minor surgery. So, and the invasiveness of the surgical procedure, like very major procedures like thoracic or the major intra-abdominal procedure, and whether the patient anesthetic technique, whether the patient will be receiving GA or central neuraxial blockade or regional, and time to resume the oral intake, how early the patient is going to resume his oral intake as well as resume his antidiabetic therapy. For example, a slightly high blood glucose levels may be accepted if the patient is posted for a shorter surgical procedure and he promptly resumes, he is just missing one meal and he will promptly resume his oral intake and he will restart his regular antidiabetic therapy by evening or late evening. And again, slightly high blood glucose level may be accepted if only if the FBS is high, and because this may be because of the stress of surgery and he might have missed this treatment. So if the HbA1c is, we can accept provided HbA1c is less than 7% and there is absence of serious conditions like DKA or severe dehydration or hyperosmolar syndrome. So, but we have to delay or postpone the surgery if the HbA1c is more than 8.5%. If the decision is made, see in certain conditions we will be forced to give anesthesia, maybe because of the infection like diabetic foot and all. So, we have to, if at all we are accept such patients, what we have to do is the blood glucose levels, should not be brought down to normal, or we should not try to normalize, because we do not know at what level these patients, because the symptoms at which they develop hypoglycemia will be set at a higher level. So one should not try to bring down in chronically hyperglycemic patients. So these are the recommendations in the preoperative guidelines by various societies like Center for Perioperative Care and Association of Great Britain and Ireland and the American Diabetic Association. So I will be telling the general protocols. So type of so again the glucose management depends on the type of antidiabetic therapy that the patient is going to receive, or receiving. So we can classify the treatment into non-insulin therapy and the insulin therapy. Non-insulin therapy, we have the oral hypoglycemic agents and the non-insulin injectables. Of late we find that there are not only insulin, we have non-insulin injectables which are available in the market, that is mainly glucagon-like peptide agonists. So they act by increasing the production of insulin, and of late we have heard of Ozempic or the semaglutide, which can be given even once a week. So, and the other, coming to the next mode of therapy is the insulin therapy, and again insulin therapy depends on whether the patient is being posted for ambulatory or a major procedure or an emergent or urgent surgery. Now coming to the protocols for OHA, majority, we all know that majority of the type 2 DM patients are treated with OHA. Among the biguanides, but metformin is the most common, and this can be continued up to the previous day of surgery, and on the day of surgery better to discontinue. But the Center for Perioperative Care guidelines recommends that metformin can be continued even up to the day of surgery, provided there is no renal dysfunction or no contrast being expected to be used in the intraoperative period, because that is going to produce lactic acidosis. So, but to be on the safer side, in most of the centers they avoid metformin on the day of surgery. And coming to sulfonylureas, we know that they are insulin secretagogues, so better they are discontinued on the day of surgery. And glitazones better to be stopped because they have similar effect on the insulin secretion. And one problem with these glitazones are they are known to produce a fluid retention. So one has to be careful wherever you are expecting the patient to have a heart, susceptible patients, it can lead to fluid retention or edema and worsen the heart failure. And GLP agonists and that is glucose GLP-1 agonists and dipeptidyl peptidase, that is DPP-4 inhibitors, they may be continued up to the day of surgery, but still there is no uniform consensus on continuing this or discontinuing on the day of surgery. Still research is pending, but most of the reviews recommend to continue on the day of surgery. So, and sodium glucose co-transporter 2 inhibitors should be withheld at least, some people say 24 to 48 hours. Ideally better to avoid them for 48 hours before surgery, and because they all act after the meal, so during fasting they are known to produce euglycemic ketoacidosis. And one more problem is because they result in a glycosuria. Whenever patients are, in addition, if they are on diuretics, they are known to cause severe hypotension on table. So better to discontinue for about 48 hours before surgery. Now, if the patients are on OHA and being posted for ambulatory surgery, and if the sugars are well controlled, better to continue OHA till the day of surgery, skip on the day of surgery, resume medication once the oral intake is allowed. Patients undergoing major surgeries but sugars are not well controlled, better to switch to insulin and to be admitted at least 48 hours before, and management will be similar to insulin therapy. Now coming to insulin therapy, again depends on whether the patient is on type 1 diabetes or type 2 diabetes. And again the insulins, we know where there are various types, and type 1 diabetes, because they need to have a background of, because they don't have insulin at all in the body, they need to have a continuous subcutaneous insulin. So most of them may be on insulin pumps, but these insulin pumps are not very practicable during the intra-op period for various reasons, like fixation problem due to position changes, cautery usage, it has to be kept away from the cautery, and it's quite expensive, and expertise is needed to operate the insulin pump. So alternatively, in such situations, IV insulin infusion can be, sir, few more minutes. So among the short-acting insulins, timing of the insulin has to be known, and if the patient is on both morning and evening dose may be continued, and morning dose has to be skipped on the day of surgery, and one should check the sugar on the day of surgery. And for long-acting or intermediate, the dose can be reduced by 20 to 25% on the previous day, and morning of surgery one has to reduce the dose to 50%. And pre-mixed insulin, reduce the dose by 20 to 25% on the evening and hold the insulin completely on the day of surgery. So intra-op management, majority of the studies have reported that for every incremental change by insulin by 20%, there will be an increase of adverse events by 30% in the post-operative period. So the goal is to maintain moderate goal of 140 to 180, because in cardiac surgeries, though the strict regimen insulin intensive therapy has led to the decrease in the incidence of sternal incision infection, but there are lots of evidence of hypoglycemia, so better to maintain a moderate goal, and preferably all elective diabetic patients need to be posted as the first case unless otherwise contraindicated. For ambulatory surgery, where the patient is going to just skip one meal, the blood sugar is well controlled, and if the patient is on OHA or insulin, the blood sugar has to be controlled before taking. And if the patient is posted for daycare surgery and patient is expected to eat in the evening, the following instructions which I have already described, so I am not going to repeat. So for inpatient major surgeries lasting for more than 4 hours, all anti-diabetic drugs including insulin, any type of insulin, to be withheld, and blood sugar and serum potassium have to be done on the morning of surgery. So the traditional method of sliding scale is not, has got certain disadvantages because it does not take the daily dose of insulin requirement, and every time there is fluctuation in the blood glucose, one has to change or discard the fluid. So the most commonly recommended method is variable rate of insulin infusion. So we have to start a insulin infusion along with a fluid of, there are various controversies regarding the fluid also. Some people recommend RL, but again RL can be used, but 1 liter of RL is known to increase by about 18 mg/% or 1 millimole of blood glucose. So balanced salt solution most commonly recommended is 0.45% dextrose normal saline, and monitor blood glucose every 2 hours and 1 hourly if the patient is unstable or patient is having, patient is from ICU. So the GK infusion most commonly recommended is the Vellore regimen. So 5% dextrose is taken in burette, but is by measuring the 1 hour requirement of the fluid is filled in the burette, and blood sugar is measured using a glucometer, and that blood sugar value is divided by 150. But if the patient is on steroids or infection, the denominator changes to 100. So the calculated insulin will be added to the burette to the maintenance insulin. If required, 10 millimoles of potassium chloride has to be added. So this goes on repeating till the surgery gets over. And this method has the flexibility of administering both insulin and glucose, so the catabolic state is prevented. And the change of fluids every time blood fluctuates is not there. Now rule of 1500 or 800 is there, this not very regularly practiced. So this by dividing that 1500 by the total daily insulin, it gives a value of blood sugar, how much each unit is going to reduce. So accordingly you have to calculate and food. But the advantage is it takes the daily dose requirements of insulin. Now rate of adjustment of insulin infusion depends on the type of insulin that the patient was taking regularly. If the patient is on long acting insulin like Glargine the night before, the infusion has to be reduced by half for the first 2 hours. Later it will be adjusted according to the blood sugar values. If the patient is receiving Glargine in the morning and blood sugar value is more than 140, there will not be any change in the infusion rate. If an intermediate acting, half of the dose can be given, but one should watch for hypoglycemia. And hyperglycemia in non-diabetics, which I told already, if persistently blood sugar is more than 180 milligram, that has to be treated on par with the diabetic patient, and one has to follow up the patient in the postoperative period. So route of administration preferred is IV, as I have told. And intraoperative blood glucose has to be monitored every 1 to 2 hours. And post-op management depends on whether the patient was posted for non-cardiac or cardiac surgeries. In non-cardiac surgeries, the infusion can be continued till the patient takes orally. So at least he should be taking 50% of the solids, and he may resume subcutaneous insulin later with 6-hourly monitoring. In cardiac surgeries, the infusion has to be continued at least for 24 hours after surgery if the blood glucose is more than 180 milligrams. And if the patient is stable and shifted to PACU, correctional insulin subcutaneously with glucose monitoring every 2 hours needs to be done. And how to transit the patient from PACU to surgical wards. So correctional insulin may not be sufficient. So nowadays what is recommended is, depending on whether the patient is nutrition intake is good or not, basal bolus and the basal plus. In basal bolus, it is utilization of a background of long acting insulin with prandial rapid acting insulin. So this is better when this is better than sliding scale, and when the patient is having good oral intake. And basal plus is recommended in where oral intake is poor. So here, along with the long acting insulin, correctional rapid acting insulin is used. Again, this is better than the sliding scale. Now a few words about hypoglycemia, because this is one of the most common adverse event we come across in patients receiving insulin. And symptoms may be masked under general anesthesia and in sedated patients. So one has to be vigilant, and constant monitoring is vital. And one must be alerted once the blood sugar comes to 70. So how to treat this hypoglycemia? Especially if at all it happens in the postoperative period, patient is able to take orally. We can give oral glucose or the carbohydrate rich feeds. And if the patient is drowsy and not able to take orally, 50 ml of 50% dextrose. This needs to be repeated till the blood glucose comes to 100 milligram per deciliter at least. And if hypoglycemia is refractory, glucagon can be given subcutaneously or IV. Now I would like to conclude that diabetes has got tremendous impact on surgery and anesthesia, and both hyper and hypoglycemia definitely increase the mortality and mortality. So an appropriate preoperative evaluation and optimization of the hyperglycemia is very imperative in diabetics for better postoperative outcomes. Currently there is no evidence or support. So perioperative intensive insulin therapy, so moderate goal is recommended. And even in cardiac surgery patients, maybe 100 to 140 milligram would be better rather than going for very strict monitoring, very strict regimen. And a moderate glycemia definitely has helped to reduce the complications even when they are followed up in the postoperative period. So adequate glycemic control and monitoring is more important than the type of the regimen. These are my references, and thank you.